Today we're talking about admissions and reimagining the admission from the patient and family chair. At Multiview, we always talk about the patient and family chair and the feeling that we as an organization are focused on creating for the patients and the families that we serve. And so a lot of what we talk about today might be different than what you're used to or how you do admissions today. But I'm hoping that I can teach you a few things that will help the feeling that you're trying to create for the patients and the families that you serve. And I'm going to start by asking you to channel your inner humility, right? And to be open to some of the things that we're going to talk about today. Like I mentioned, it's not what the median out there is doing. The average hospice on the street is doing a 4-hour admission. It makes me sad to say that, but it's true. And I don't want you to be doing a 4-hour admission. So I'm asking you to keep an open mind and maybe really consider approaching things from the patient and family chair. At Multiview, we focus on the 90th percentile. We're not particularly interested in what the hospice down the street is doing because it's probably what all the other hospices in your area are doing. However, we are very interested in what the 90th percentile are doing. We want to focus on those outliers, and we want to take some of the things that they're doing and again, use them to really focus on the feeling that we're trying to deliver to that patient and that family on that very first day that they're beginning to receive the care from our organization. We talk a lot about the bell curve at Multiview, and the thing I want you to remember about the bell curve is that you choose where you are on the bell curve. You do not need to do what the hospice next door is doing. Be bold, be courageous, do things differently. There's really one major thing that I want you to focus on when you are approaching your admissions and your admissions team is approaching their day, and that is reducing the direct time that we are spending with the patient and the family, as well as the overall time. But really, again, from the patient and family chair, let's reduce that direct time that we're with that patient and that family. And here are some of the things that we have seen those outliers doing in their admissions visit. Again, speed. Speed is the number one characteristic of a successful admissions team. The first hospice there is going to get the admission. Speed is a huge component, and I actually believe that most hospices out there totally get this. But the other side to that is time is what matters most to the patients and the families. And we are in their home, we are guests, and I want us to be really respectful and intentional about the time that we're spending with the families and reduce that time as much as possible. Here are some things that an admission visit is not. An admission visit does not need to be a head-to-toe assessment. Yes, there will be some patients that are more challenging to find the thing that it is that says, absolutely, this patient is appropriate. But there are a lot of patients out there that it's pretty straightforward. So let's just do enough an assessment to absolutely prove beyond any doubt that this patient is hospice appropriate, and then we're going to stop. That's it. That's all we need. A hospice admission is not a detailed life history visit, right? We talk a lot at Multiview about how if it feels like a trip to the doctor's office, you're doing it wrong. We don't want the family to have to tell their story over and over and over. And the admission visit, generally speaking, the family's tired. I mean, let's be honest, Friday afternoon is our busiest admission time. And that family has probably been sitting in the hospital waiting to be discharged for most of the day, and they're exhausted. And they probably aren't ready to tell us their full, detailed history. That can wait. An admission visit does not need to be a complete chronic medication review and deprescribing discussion. We have to look at the medications. That's an important part of the story. But again, We don't want to have a lengthy discussion about deprescribing. We don't need to go through every single medication they've ever been on. Let's address the things we need to address, and let's move on to the next thing. I actually spoke with the wise and wonderful Jennifer Kennedy just the other day, and she confirmed for me that there are no specific regulations for the medications in an admission visit. So work with your compliance team and your hospice, work with your admissions team and help them understand what are the things that we need to know during that admission and what are the things that can wait until the nurse case manager comes and follows up probably 24 hours within that admission visit, but pretty shortly thereafter. Let's let the nurse case manager handle all of it. At that admission visit, let's focus on only the things we have to focus on. An admission visit is not a comprehensive education session. Again, a lot of our admissions take place on a Friday afternoon. The family is exhausted. They've been sitting in the hospital waiting to be discharged. They simply don't have the capacity to learn everything that they need to know to care for their loved one. We absolutely are going to teach them everything they need to know, certainly overnight, within the next 24 hours until their nurse case manager arrives and teaches them more. But the bulk of the education should be coming not during the admission visit, but in subsequent visits. An admission visit does not need to be a full care planning discussion. It is perfectly acceptable to say things like, edema present, not assessed. We're allowed to do that in an admission visit because when the nurse case manager comes in and does her follow-up visit, she's going to address the entire full care plan. That is her responsibility, and the family simply doesn't have the capacity to have that entire conversation during that admission visit. All right, I want to talk about the hiring profile for an admissions team. I want your admissions team to have an abnormal level of energy. We all know that person, right? We're in a meeting and their leg is constantly going, right, during the meeting because they have that abnormal, natural level of energy. That's the person I want leading my admissions team. We also need to see an ultra high sense of urgency. I want every single time that phone rings, I want our admissions team to be thinking, how am I going to get there fast? How am I going to get there fast? I want the team to have an ultra high sense of urgency. The manager of the team is the person that is going to model and the team's going to replicate the energy of the manager of the team. So we definitely want to have the person leading that team with both of those characteristics, an abnormal level of energy and an ultra high sense of urgency. Did I mention that we want an abnormal level of natural energy and an ultra high sense of urgency? That's important. Don't hire or place someone on the admissions team if they don't possess these characteristics. Speed. I know I'm going to talk about speed a lot in the next few minutes. Speed. We want our admissions nurses to stop doing obsessive compulsive admission visits. Tell me if you agree with this, and if I'm wrong, I'll admit it. But I think what happens is the admission nurse thinks, oh, I'm going to do the nurse case manager a favor and I'm going to check all the boxes and I'm going to do all the things and I'm going to tie a pretty bow on top and I'm going to hand it to the case manager. Well, guess what? That case manager wants to see those wounds with her own eyes. She wants to do that full assessment herself. She needs to do that full assessment herself in order to be able to care for that patient in the best way possible. So when the admissions nurse is doing an obsessive compulsive visit and the nurse case manager comes in the next day and does all the same things, we are torturing the patients and the families that we're serving. Don't do it. All right, the goal of the admissions visit. We want to do a very quick assessment wherever possible that gives plausibility that, yes, this patient is hospice appropriate. They are eligible on many fronts, and we're going to document that. Then we're going to get the patient comfortable. We're going to address the immediate needs of the patient and family, and only the immediate needs of the patient and family. And then we're going to get out of there. We have 5 days to do the comprehensive assessment. That's a CMS COP, friends. 5 days to do the comprehensive assessment. We can do an initial visit during that admission visit, and that is perfectly acceptable to CMS. With each interaction with the families, we are creating the experience or the feeling. So let's be really intentional during that admissions visit. Every activity, especially these initial contacts with the family, this is the impression that we're building. This is us showing the family who we are. And we want to be very intentional about the things that we do and the way that we say them in order to be able to create that feeling. Here's some ideas, some things that you can say. I know that you have a lot happening and you may be overwhelmed. I'm going to do the basics and get you comfortable. Or your primary nurse, Nurse Nancy, will be visiting tomorrow and she will do a more comprehensive assessment. My job today is to get you comfortable. Let's manage those expectations. I promise you the family is going to be grateful. The admission visit should be reduced to a much shorter period of time, eliminating all things that can and should and will be addressed later by that nurse case manager. The personal inspection of the patient and just enough H&P to make that professional judgment that the patient is hospice eligible is enough to get that patient admitted. All right, this is the mindset that we want to instill in our admissions team. Admissions visits can be done in a relatively short period of time. That's the message that I want you to send to your admissions team. I can't tell you how many hospices that I've gone into over the years, and they do a 4-hour admission visit, and they're proud of that. And I just want to challenge you to think from the patient chair. If that was your loved one, and again, you've been sitting in the hospital most of the day waiting to be discharged, you're not feeling good, you just don't have the capacity to endure a 4-hour visit. We want the admissions team to have that mindset that a shorter visit is a better visit. We want the admission visit to be more like an hour, maybe 90 minutes tops. That's direct time with the patient and the family. There's obviously going to be travel time and things like that. We're saying 60 to 90 minutes in direct time with the patient and the family. That should be the admission team's goal. All right, in cases where there are a lot of referrals and a hospice wants to grow quickly or keep the admissions nurse moving, here are some of the practices that we've seen the 90th percentile doing. So you can create medication templates and modify them by disease type. That's a great way to speed up that medication process that needs to be done during the admission, but it doesn't need to be a full, it just needs to be the immediate needs. The admission nurse has support people that do a lot of the coordination and administrative functions in order to enable the RN to admit more patients, right? So the RN goes in, we want our clinicians working to the top of their license. So have that nurse in that home doing the things that the nurse needs to do, and have support staff that are doing things like ordering the DME, ordering the supplies, and handling the ordering of the medications. These are all things the nurse needs to be a part of, right? She's the one with the license, she's making the decisions, but as far as the administrative tasks and the coordination of activities, we don't need to have an RN doing those things. We can utilize non-clinical people to help with these functions in order to free up our nurse, right? Our admissions nurse, to go out and see more patients and get more patients on service faster. Of course, the support staff typically cost a lot less than somebody who's got a license. So from a fiscal responsibility perspective, it pencils. Find that single admission nurse who does a short visit and model her behaviors. You all have somebody on the team who's super fast, can get in there, can get out, is really good at identifying things. That's the person that we want to model our admissions visit after. We want to model their level of energy. right? We talked about an abnormal level of natural energy and a sense of urgency. We definitely want to model that for that admissions nurse who's doing those short, quick admissions. We want to model the documentation style of that clinician. We want to model the way that that clinician plans her visit, and we want to model that clinician's clinical practices. Okay, most of you know, if you are fans of Multiview and you've been in our world, the number one goal of the visit is to make the caregiver the hero, and that absolutely is still the case for a routine home care visit. However, the admission visit has its own goal. It's different. For the admission visit, we want to limit the exhaustion and stress of patients and caregivers by doing a speedy and compassionate visit. That leaves the vast majority of the teaching to the rapid follow-up nurse and the rest of the team. Only what they need to know to get through the night. Leave everything else up to that nurse case manager. All right, some things to keep in mind. This is a new mindset. I know how challenging it is for some people to not do all the things, but I'm asking you to consider it from the patient and family chair. We don't need to do all the things during that admission visit. We don't want to appear rushed either, though, right? We want to get in there, we want to do what we need to do, and we want to get out without appearing rushed. If the family needs to tell their story, we're going to let the family tell the story. But I'm telling you, the majority of the time, the family's exhausted and they just can't say it again. We want to recognize that the longer an admission visit lasts, the less quality experience is created. That is one of the most challenging myths that I deal with on a regular basis when I go to visit hospices. A lot of times clinicians feel like more is better. It's not. It is sacred time at the end of life, and this family only has a little bit of time left. We want to be respectful while we're in the home, and we want to get out, and we've got to destroy that mindset that the longer is better. For an admission visit, the longer it lasts, the less quality experience is created. Long visits are stealing non-redeemable time from that family. And then also the sensitivity of the admissions team needs to be top notch, right? You need to know when you walk into that room, you've got to read the room, and you can't be Pollyanna sometimes walking into a room where everybody has just gotten the news that the treatment didn't work and hospice is the right option for them. We've got to be sensitive of things like that. We want them to be sensitive to what the caregivers are able to, again, what their capacity is to learn in the moment. We've got to teach them the things that they need to know to get through the night. We can't leave until we know that they know them. But anything beyond that is too much, and we need to let that wait until the nurse case manager arrives the following day, and they can take care of that stuff and the rest of the team in subsequent visits. We need to be sensitive to anxiety levels, and admission staff has got to be able to pick up on those behavioral cues. Minimal teaching is done during the admission visit. More is done during subsequent visits. I know we say at Multiview, I am a teacher, and we say it at the beginning of every visit, and absolutely you are a teacher. And when you are an admissions nurse, you are a teacher of only the things that they need to know to get through the night until the nurse case manager can come back. They simply don't have the capacity to learn all the things that we need them to learn on that first visit. We call it chunking, right? So this is when less is done during the admission visit, more is done during subsequent visits, mostly related to teaching. And the teaching is incremental and is staged according to the ability to benefit from such teaching. Again, there's not a lot of capacity during that admission visit. We have to be very intentional, make sure that they know the things that they need to know to get through the night, and then we need to stop. Only the most basic and essential tasks are done during the admission visit. We're huge proponents of a special and dedicated admission team at Multiview. We think that the skill set of the admissions team is different and unique than it is for a routine nurse case manager, and we want to hire for We talked about the abnormal level of natural energy and an ultra high sense of urgency. Those are just two of the characteristics of that admissions team. We definitely love the idea of having a special and dedicated admissions team. So, admissions should typically not be done by case managers. An admission nurse is a specialty position and it requires people with different skills, right? If teams are allowed to do their own admissions, in our experience, they tend to self-regulate. Please don't hear me, they're doing it intentionally. It's not what I'm saying, but it happens. The teams will self-regulate, and that's one of the reasons why we want to keep the admissions team separate from the clinicians who are out in the field. If the admissions team perceives that the clinicians are over stimulated, that they have too much going on, the admissions team tends to self-regulate. We don't want that. We want them out there doing that ultra high sense of urgency. We definitely want them out there doing more admissions. Only in remote areas or in specific situations would that nurse case manager be asked to do an admission. The admission in general disrupts the nurse case manager's day. But with that said, every nurse needs to know how to do an admission. There are occasions and specific situations where it's necessary for a nurse to be able to do an admission visit. And so we want to make sure that they have the ability to do that, but it should be our plan B. Our main goal is always to have that special and dedicated admissions team out there doing those admissions. And I want to mention, I know if you're a small hospice out there, you probably don't have the ability to have a dedicated admissions team, and that's okay. If you can't do it, you can't do it. I want you admitting patients. Everybody can do it. But at the same time, once you get to a certain size and you're able to carve that function out, I think it brings a lot of value to the organization and it can really impact your census. All right, I mentioned this earlier. The physical placement of the admissions team should be away from the clinical teams. If the admissions team perceives that the clinicians are busy, they tend to self-regulate. And again, not necessarily in an intentional way, but it just seems to happen. When you want the gas pedal down on admissions, you have to separate the admissions team from the clinical teams. All right, admissions are a clinical decision and they should be done by NPs or RNs or physicians. At Multiview, we are not proponents of a nurse social worker dynamic in the admissions. We like to see clinicians doing admissions. The EMR needs to be streamlined for documentation, for the admissions process. We need to make the EMR work with us, not against us. So find that super user in your organization, have them sit down with that nurse who does those short and speedy admissions, walk through the process, eliminate all of the things we don't have to do during that admission visit, and help that EMR keep our admissions nurses moving. Documentation has to be concise. We want it to be graphically descriptive, right? That's another skill set of our admissions nurses. They have to be very good at painting the picture that this patient is hospice appropriate. The amount of time it takes to document in your EMR is where you start building your model visit. The primary driver of cost is time. We want to shorten that time wherever possible. And if you take your best clinician and the amount of time that individual can do an admission in, maybe add 5, maybe 10 minutes tops for the rest of the team. But again, model that visit, teach that speedy, short visit. Our productivity expectations, 10 to 15 admissions per week per FTE. Now that's gonna change depending on if you have an admissions team who's working 5/8s or 4/10s. It kind of is gonna vary, but I wanna see our admissions nurses doing at least 10 admissions in a week. Remember, I asked you to keep an open mind. That's what I'm saying, 10 visits in a week. A Florida hospice that we work with doubled their census with just one move. They replaced the leader of the admissions team. They replaced that leader with somebody with an abnormal level of natural energy and an ultra high sense of urgency. Have I mentioned that? From an ADC of about 200 to over 400. 7 is the most admissions we've seen done by a clinician in a day. That's what I said, 7 in a day. Okay, I want to show you the sunny day perfect admissions visit, and I'm not going to spend a ton of time on it because I know all of you are familiar with the sunny day visit already, and there aren't a whole ton of things that are different, but there are a few things that I want to point out. So at the top, the first line, the goal of the visit: offer peacefulness, give hope, bring love, comfort, and support. The goal of the regular visit: to make the caregiver the hero. It's a different goal with the admission visit. We want to offer peacefulness, give hope, bring love, comfort, and support. Again, the only thing the caregiver is going to remember is how we made them feel, which is why we have those yellow highlights. You all know that. The first phase of the admission visit, almost identical to the first phase of the regular home care visit. The only difference is that we're going to review those clinicals when they're available. Phase 2 is a little bit different though. Phase 2 is our entrance, and at the admission visit, we are focused on offering peacefulness, right? So easy does it as we walk into the room. And this is one of those aspects or one of those skills that we want to look for when we're hiring for the admissions team. We need somebody with an ultra high sense of, or somebody who's very good at perceiving when they walk into a room. We need to know the level of energy of the room that we're walking into, and we need to match that level of energy. We can't be up or way down. We've got to be where they are. We want to read the room, and that's so important in an admission visit. Again, we want to match the level of energy in the room. Introductions. What do you like to be called? Let's ask the patient what they like to be called. You've probably read the chart, and their full name is probably in the chart. That is unlikely to be the name that they want to be called. Let's ask them. It seems like such a simple thing. It makes a world of difference. Talk to the patient. Please talk to the patient. We need to talk to everybody in the room, but the patient should be the person that we're talking to. Dig. I love this line. Tell me what the doctor is telling you. You know what the doctor is saying because you've read the chart and you understand the way the doctor speaks. But what we need to know is what the family thinks the doctor is saying. That's an important nuance. Listen, let them tell their story. Some people are going to be exhausted and they're not going to tell you much. Other people are going to need to talk, and we need to listen. What's your biggest concern? Just like the regular visit, we need to understand what their biggest concern is today. And while they're telling us what that concern is, we're going to use our whole body listening, just like in our routine visit. And here we're going to do a little bit of probing, right? We're going to ask them about their treatments. We're going to ask them about appointments. We're going to ask them about hospitalizations and their DNR. And we're going to ask them, do they have prior hospice experience? What we're getting at here is we need to understand if they are on the hospice page, if they're ready. And we need to do what we need to do to get them there if it's at all possible, but we need to understand where they are. And then the last thing we're going to do is introduce Mr. Gates, because that's what everybody else on our team is going to do. And we want to start that expectation on the very first visit, on the admission visit. Pull out Mr. Gates, help that family understand that this device is the best way that we can be an effective interdisciplinary team. Phase 3, give hope. Here's how we can help. A lot of people think they understand what hospice is. Most people don't understand what hospice is. Help them understand how we can help them. We want to tell them about specific services, specials that apply to them, only what they need now, right? So if you were talking to the patient and their biggest concern was their pets, maybe they have 2 dogs and a cat, and they're concerned about what's going to happen to those animals after they pass, and you have a Pet Peace of Mind program, tell them about the Pet Peace of Mind program. But if they don't have any pets, don't mention the Pet Peace of Mind program. Only tell them what they need to know now. Again, there just isn't the capacity to help them understand all of the services that we provide. And we need to make sure that they understand the most important things to them. Only what they need to know now. And lastly, we're going to manage expectations. And I can't tell you how many times I walk into a hospice and the clinicians are complaining because either the admissions team or the sales team has overpromised all of the wonderful things that we can do for this family. Let's make sure that we manage expectations. Yes, we have aid services. Yes, we can help you with a lot of things. No, we are not likely to have an aide in your home 7 days a week. Let's make sure that we manage those expectations so that they understand how we can help, but we aren't over-promising and under-delivering. Phase 4, professional judgment. We're going to do the assessment here. We're going to confirm the primary diagnosis, complete the admissions template if we have one. Again, only enough to establish that this patient is hospice eligible. We want to review the handbook if we have one, show that to the patient. But again, not too little, not too much, only what they need to know now. Our subsequent visits, all of the clinicians that will be in the home should be referencing that guidebook. We want to make sure that they know that they have it, that it's a resource for them, point out just the things they need to know today, and leave it at that. Medications, again, there are no specific regulations from CMS on what we've got to do with medications. We don't have to do all of it on the admission visit. Decide as an organization what you need your admissions nurse to do on those admissions visits. Leave the rest up to the nurse case manager, who will be doing the follow-up, more comprehensive visit. Confirm and order the DME. As we mentioned earlier, we love to have a non-clinical person back in the office who can help coordinate this stuff. The nurse is the one who will be making the decisions, but the administrative task of actually getting the things ordered and sent to the home should be done by somebody non-clinical if possible. Then we're going to rock the doc. This has patient name, age, diagnosis, etc. Determine what your physicians want to know, and only what your physicians want to know, and only give them that information. They don't need the whole entire history of the patient. Understand what they do need to know and give them just what they need to know. Ordering meds, record the one detail for tomorrow's visit. I know this isn't the regular visit, but it's so important. I'm going to talk about it for just a minute. The one detail is a very important and special aspect of the Sunny Day Perfect Visit structures. And it is when we take the time to notate something in a perfect world non-medical that occurred during your visit. You put that in the EMR so that when the next person comes in to visit, they can mention it. So the North Carolina Hurricanes, we're in North Carolina, so I'm going to call it out. The North Carolina Hurricanes are in the Stanley Cup Finals. They won last night, so they're up 3-2. If the family happens to be huge Hurricane fans, that's a great one detail. Put that in the chart so that when the nurse shows up the next day, she can mention, oh, I hear you guys are huge Hurricane fans. That's hard to say. Huge Hurricane fans. Did you catch the game last night? Who's your favorite player? That kind of thing. It really emphasizes, I think, two very important things. First of all, this is a patient and a family that we care about. They're not just a disease that we're trying to manage. We care about them as humans. And second of all, it helps to establish how important the interdisciplinary aspect of hospice is to our organization. Because even though I wasn't here during the visit, I spoke to the person who was, and she conveyed this important information to me. So let's keep the one detail in the visit. Moving on to the last phase, we're going to set the expectations. I think this is really important. The family has a lot of questions. If you have a handbook and you can write this stuff down, I think that's ideal. They need to understand when that follow-up nurse is going to arrive, and that the person coming in next is going to be the person who is primarily responsible for them, that kind of thing. Help them understand when they can expect to see their supplies, their DME, that kind of thing. Make sure that you're setting those expectations realistically. We're your new 911. This is different. This is new to the family. We don't want them calling 911 anymore. We want them to call our hospice. We probably have, if we have a family guidebook, our number is probably on the cover. We might have a magnet that they put on the refrigerator. Start reinforcing from the first day that the hospice is the one that we want them to call, not 911 or not 911. We are their new 911. Reassuring and encourage the caregiver. We want to make sure as we're leaving, it's a high emotional impact visit step. We want to make sure that we're building their confidence, right? Here are just a couple examples of things you can say. We're here to give you all the tools and resources you need to take care of your loved one. We are going to walk with you every step of the way. Just build that confidence in the caregiver as we're walking out the door. And express gratitude, just like the regular visit. The offstage, exactly the same, with one slight important exception. So we're going to get a message to the team. If there were things we couldn't do in front of the patient and family, we're going to do them now before we move on to the next patient. We're going to let it go. Because if we have covered all the steps in the visit, that's the only time we can let it go, because we know we've done all the things. And then the last step, and this is unique to the admission visit, who am I calling next? Where am I going next? Let's check back in with the intake team. Let's ask them who else needs our help. Last thing I want to tell you today, and that's please, 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 as you are reimagining your admissions process, do it from the patient and family chair. Remember, we are here to simply help people feel better. And I hope some of the things that we've talked about today can help you do that. Thanks for your time. I'm grateful. Welcome back. Hey, thanks so much again for joining us today. I hope that you learned something new. I hope that I didn't offend too much with my different and unique ideas like we frequently have at Multiview.
Yeah, and the thing is, like you alluded to in the beginning, these are the practices of the 90th percentile, and I'm always shocked at looking at this, over the years. This is from hundreds of hospices, and you find those really special hospices or even singular clinicians and go, whoa, what are they doing? And then have that humility to emulate. So
I've got a message here. I've heard Andrew say that productivity is overrated. Is that idea relevant here with regard to admissions visits?
Well, I think, again, becoming a hospice philosopher, yes, often I think our life itself, we overvalue productivity. We certainly have to have a certain amount. With that said, I want 10 admissions, maybe even 15 admissions from a really top admissions. I know some people are probably falling over, but I've seen people do this. And if somebody's drawing full time, and it's almost like if a 10 and you're working 5 days, so you have the morning and you're squeezing in the afternoon, that's not overly taxing. I think a lot of people could almost do that in their sleep if we get rid of some of the clutter, especially. My thing is that I want my clinicians moving, so having that energetic support person, that's fun to work with. Another key, great attitude and all that. That's a great team. And the speed thing that Nancy brought up, what do we know? And you can put this above the admissions department in a big banner. First hospice on the scene wins. You can make the move of one personality, just one move at a hospice of one person from here to here, and a census will double. A lot of times people are complaining about census, oh, it's not great or whatever. And then you look over at the admissions person, they're kind of, I don't know, we're pretty busy, And it's like, come on now. You want that person with the energy drink right there.
And I think that's the important distinction between productivity and having your admissions team doing 10 to 15 visits per FTE. Yeah. The difference is how you build the visit, I think, right? Yeah. And eliminating the unnecessary things, and that's not then going to tax.
Yeah, now, again, I'm a CFO for one hospice, and we just picked up 100 patients a day in a relatively short period of time. And obviously we have some of our urban sites, but then we have our really rural sites where we have like 3 counties. And there, we break the rule. They do their own admissions. We don't, the model, there's not enough patients there to support the admissions team, and it would take too long to come from one of our other sites to do that. So in that case, you do your own, but they're still speedy, and you find that person with that fire to get out there. So that's probably an answer for those that have that rural, extreme geographical challenges, urban and, but even if I had let's say I was a single site in a rural area, I'm going to have specialized person doing admissions. Now, they might even have a slight caseload or whatever if you're not large at all, but hey, speed is it. And where there's provision where you can just about drop everything to go get that admission. And in a competitive environment, speed is the only thing that counts. First hospice on the scene wins, again.
All right, I have another question. How do you get around doing the HOPE assessment on the initial visit? I think you do have to do the HOPE assessment on the initial visit, but again, it's breaking it down to only what is needed and saving everything for the next visit or that symptom follow-up visit. So we absolutely want to be in compliance. We've got to make sure that assessment is being done, but again, only what has to be done and not anything in addition.
Yeah.
I got another question. Do you get medical director approval prior to going to the patient's home?
Approval for admission? I mean, we still got to put eyes on people.
If I'm understanding
I'm not putting that. I mean, but all we're looking for is a probability that they are eligible for hospice, if I can use that language. Because I'm going to take the grays, because nobody has the prognostication gauge that's perfect of when people are going to, what their disease progression looks like. And so if they're probable that their disease has progressed to that point, we're admitting, boom. And then we'll use the certification process as it was designed.
We talked about that a little bit at the very end when we went through the structure. The clinician, the nurse in the home doing that admission does her assessment. And then that's when we call the doctor. And we tell the doctor only the things that the doctor really wants to know. We don't have to tell the doctor everything. They don't want to know everything. They want to know just enough to determine, yes, that patient is appropriate. And to Andrew's point, even if it's somewhat questionable, we're going to use that research process to really determine that.
Yes. I think that a lot of times people are too conservative in their admission criteria, in my experience. That said, we're not signing up whole families and abusing it in like areas. I mean, there's some rationale behind it.
Okay, another question. What is the best way to sell the admission nurses doing less to the nurse case managers who think they don't do enough? Oh, that's all right. So I have the admissions nurses who are saying I have to do everything because the nurse case managers don't think the admissions nurse is doing enough. Okay, thank you, Catherine. I think
that's a beautiful question. Really intelligent.
Yeah. I think you have to answer it from the patient and family chair, which I happen to be sitting in.
I think almost, she's sitting in the patient family chair. Everything has to be done with the respect and dignity of vulnerable people, right there. If you were there, just like when we were admitted into hospice, my mom, well, we have the nurse and the social worker, and 3.5 hours later, and I'm giving them cues. Us kids are putting our heads down on the table, and they don't stop talking. Obviously, we had tuned out. So I think but then I think you also go through, patient-family perspective, but just pure rationality and goodness. That case manager, you're going to be looking at this anyway, right? You're almost going to do your own reassessment of the patients because that's your professional obligation, your duty of care, you might say, that has to be done. Your eyeballs on the situation. And then the way to move the admissions department is to have someone that gets it, where the light bulb goes on, that this is what's needed. And I give them the authority to do that. You can also address it through the comp system, but that's a little more of a brute way of doing it, which I wouldn't recommend. Put this way, if they're too long, I mean, someone has to lead by example, though. And so I find that wise clinician that gets that, that's not just looking at their own little situation, but is taking that more mature view of looking at the overall organization and what would be good for the organization, but above all, what would be good for these vulnerable people, because that's what they are.
Okay, I'm going to move on to the next one. So if the target is 60 to 90 minutes of direct time with the patient and family in the admit visit, is that inclusive of the documentation?
That should include the documentation. And this is where getting the skill of the perfect narrative, down, not too much, not too little, descriptor words. And if you, again, we've provided all this stuff to support these perfect visits and stuff. And you can take the guide sheet for documentation and say, well, I haven't used this word for a while, looked like hamburger meat. I know that's a very graphic description of a wound, but it surely is effective with Max and those that pay us ultimately. But yeah, the documentation where it's just don't over document. I think people in trying to prove eligibility, volume isn't the way to do it. I think is communicating clearly, describing the situation, painting the picture, as classically is said, and that they need us.
I think too, it's about designing your EMR to work with your admissions team.
That's a whole other part of there.
Not against them. Yeah.
Yeah, because it's just like people customize their systems. Like, this is no kidding. This is one of the hospices I was a CFO for. 26 screens to admit a person. And I just blew up the whole thing and got it down to 5. Said, we don't need all this. And of course, people are screaming, well, I've got to have this. Well, you have to have that piece of information because in 1985, we had an incident. And it might happen again.
All right, I'm super glad to hear the echo is gone. I know I'm a little delayed here. Okay, moving on. Do you recommend the admitting nurse getting the consents signed or non-clinical person?
I'm a clinical person. I think putting more bodies out there, you kind of confuse people. Hey, I'm the signer person. And even though first hospice in the scene, they will tend to go along with that. I just like one and done. If I'm in the patient chair, one and done. I don't need a lot of personalities coming in.
Yeah, I think there might be certain circumstances, like at a hospital, if you're signing consents and you're not going to get discharged. So maybe there are certain specific circumstances, but I'm with you. Overall, I want a one and done.
Yeah.
Yeah.
So the patient chair answers the question.
All right, it feels as though we need a high sense of natural energy and urgency and exceptional documentation to minimize the need for follow-up questions between clinicians and visits. I completely agree, Danielle.
Yes.
And it says,
wonderful.
Is Andrew saying, oh, right. Sorry, guys. I'm having trouble with my mouse. Here we go. Okay. Yeah, Andrew is saying this right now. Yes, thank you. Okay. And then I have another one. If we have implemented having an LPN or RN float do the first visit after admission, and there are a lot of medication sorting, weeding to do when the RN case manager's caseload is higher. This has helped with efficiency for both the admit nurse as well as lessens the stress on the nurse case manager. Okay, so this is an example of a practice that an organization is doing. In my perfect world, that regular nurse case manager should be doing that follow-up visit to the short admission. Because to your point earlier about confusion, like I want the family to understand this is the nurse who's going to be my primary nurse going forward, right? I mean, that feels good from the patient and family chair, that consistency of care.
Yeah, and I'm not saying that it's not an effective practice, you know. I mean, it's just like we've got models where the LPN and RN are teamed up. In that case, both of those are part of that interdisciplinary team, and that's down to the style of the hospice, which is fine. You just have another personality in there. And so, again, I have no problem if we're getting a great result.
Absolutely.
Again, quality result in the eyes of the patient family, as well as our own efficiencies or lessening of the workload. Well, then that's rational.
And if you go back to that ultra high sense of urgency, right? There are patients out there who need our care. And so anything that we can do to get that admissions nurse admitting another person on our service so that we can start helping that person right away. If this practice helps us get that admissions nurse doing more admissions in a day and we still can take good care of the family with this interim person, I'm absolutely in favor of it.
Sure.
100%. Okay, another one. What goals and interventions do you suggest for the admission/initial plan of care? I mean, I think address the immediate needs, right?
Yeah, I mean, definitely whatever the immediate needs. I think the thing is, if we've been doing hospice a long time, we tend to get the same diagnosis groups. They tend to follow a pattern. Okay, intelligence is pattern recognition. And I think getting your templates down, okay, we've got lung cancer. Here's the lung cancer. Boom. The definitions that go into the normal plan of care like that. So you're not making a brand new thing, every time. You're starting with a baseline of knowledge. I did this at Winston-Salem, my very first hospice. I got all clinic, because HMS, which was the my unity of the day, or whatever. I'm not. They had this feature, and I thought we need to start using this. This could be of great help and decrease errors and that. So that I would definitely go there, and it's more of a proactive. Now, I'm not saying all EMRs have that type of feature, but it's something that could be developed, and especially even some of the narratives we'll have, because again, diseases follow similar trajectories. And let's face it, you're addressing the immediate right now, because you don't, the crystal ball, even though it may be somewhat predictable, you don't have to go to that yet.
Okay, so I have another comment here. Those identified in the symptom impact screening will keep plan of care fast, focused, and easy to track for admission. Thank you, Danielle.
Oh, right.
It's awesome.
We need to rip that one off.
It's in the chat. We might steal it, Danielle.
I was going to say, we'll give credits and just tell us where the royalty checks to be sent to, and we'll oblige.
One last question. I'm fired up and ready to build this, pilot it, and operationalize it. Thank you for this incredible presentation. I can't wait to see the outcomes possible. Let me see what you build when you build it, Danielle. I'm super excited for you.
No.
One last plug for the compensation survey. If anybody out there is interested, that's going to be open until, I believe, August 1st. The link was earlier in the chats, and you can get on our website. And we hope to see you July 21st at the Compensation Tough training to learn more about the 4-day work week. One more.
Yeah.
Sorry. What medications would you not add to the MAR on admission? I'm assuming over-the-counter vitamins. Also, why would you not add them? So I think what I want you to take away from this is that we don't have to do all the things every time, right? It's about making sure that we're documenting all of the things that they're going to need, certainly over the next 24 hours, maybe the next 48 until the regular nurse case manager, their primary nurse case manager comes in and addresses everything. So yeah, I would guess over the counter, I think your admissions nurse is going to want to see them. And she's going to use her professional judgment as to the things that she needs to document from that visit. And I think that that's a conversation that you want to have with your compliance team. But I think understanding that there is no specific reg that CMS has as to what you have to put in for the medications on that initial admission visit. So you decide what you're comfortable with as an organization, and just know that you don't have to do everything on that first initial admission visit.
Yep.
Does that help, Megan?
There is a bit of a sales job, or sales equals teaching. But so, becoming a master teacher, and being able to get, again, the ideas into the minds of other people. But again, the patient share is where we start.
Always. Thank you, friends.
Thank you so
Appreciate
much.
your time.
Thank you.